Hi friends, it's Dr. Russ. We have another shoulder treatment video for you today in keeping with our recent theme. In this one, we found some restriction in Megan's clavicle, glenohumeral joint, the lat serratus junction on the side of the body wall, and a couple of trigger points that were reproducing pain that looked like impingement syndrome but wasn't actually impingement syndrome. Thought it would be interesting for you to see all that. I really appreciate you watching, and anyone who has joined the channel or purchased their supplements through our full script dispensary, thank you. Every little bit helps a lot. And if you're watching this video and you enjoy it, you want to know how to support the work that we're doing, there'll be instructions in the video description below. So thanks for watching. I hope you enjoy and learn from this video, and I'll see you again soon. Megan is describing pain and tension in the left shoulder. She feels it around the upper trap, in the pec, and like a clicking and a little restriction when she tries to abduct in that direction. That sort of sounds a little bit impingement-y. So the glenohumeral and the acromioclavicular joints being restricted, putting more stress and more strain on the pec and on the upper trap. And so sometimes that's where the symptoms really show up, even though the main problem is in the glenohumeral or the AC joint, or of course sometimes the SC joint. So we're gonna have a look at all of those things and just kind of remember those important relationships in this part of the body. The scapula on the rib cage, and we need that scapula to be able to move really freely on the rib cage. The mobility of this joint right here, the sternoclavicular joint. And in terms of just kind of a visual inspection, hers are really nice and symmetrical, but that does not mean that that's necessarily moving really well. The mobility of the clavicle, which affects the acromion, which affects the whole shoulder. So we're looking also to remember the three pectoral muscles, the clavicular, the sternal, and the pec minor. And coming off of the coracoid, the coracobrachialis, the short head of the biceps, and the pec minor. That tension and tightness in those three will pull the shoulder into some protraction, internal rotation, which then puts a lot of strain on the upper trap. And so just kind of initially, my initial assessment here is that there's restriction of the clavicle. It doesn't move very well. Yeah, you feel that, feeling a little stuck. And there's restriction of the coracoid, and she's a little protracted there. So let's just kind of start by giving a little nudge to that coracoid process and see if the scapula is even able to sort of passively move, and it is. And it feels much more like the restriction is here. So right here, we can get a nice close shot there, is the head of her humerus. Right here, there's the ball, and the glenoid is going to be right there, the socket. And it's very restricted and firm, right? Doesn't move that well, especially in that A to P direction. I mean, we like to see a little bit more ease of movement there. But if I rotate it, it's actually got really nice roll and glide in this. So her difficulty with abduction is not so much about the spin as it is about the glide. So there, we'll do that. And, you know, I just like to work the biceps because there's so many trigger points in the biceps and so much phone work, right? Right hand, left hand. Also, if your patients have small children that they're holding. So let's say if they're right-handed, they're probably going to primarily hold a small child in their left hand. So their right hand is free, and they're going to get some overuse type trigger points in their biceps and brachialis muscle on that side. But Megan does not have a small child. She has a big child. And so, but you can see here is her biceps here, and it's really bunchy. So making a note of that. Come back to that in just a minute. And I'm working fairly deep. You can see how much pressure I'm using by the how my thumbnail turns white. Been working with Megan for a long time, and I know that pretty direct work works pretty well for her, would you say?
Yes.
Yeah, so we're kind of going right for it. So here we are. Here's where we're going to start. Her biceps and this trigger point, just flush it out, give it a little compression, and get some fresh circulation into there. Next step is here is her anterior deltoid and coracobrachialis on this side of my thumb. And here is the long head of her biceps right there. You can see it kind of snapping that tendon as it goes right through the shoulder capsule. Sorry, Megan, right there. And what we need to do is get some mobility through these layers. So we want the anterior deltoid to kind of stay in anterior deltoid land so that the biceps is free to move. And her tissues are very responsive. She's taking really good care of herself, so it's pretty easy to work with. So let's see what that might have done to our resistance on the humeral head, and it's much more springy now. Can you see that from where you are? Good. Okay. So that brings us back to here, that coracoid process, and much more mobile. And a nice one. I kind of spring it from A to P. She gets nice reactive movement in her head. That's good. We don't want it to be really stiff, right? We want her body parts to move well together. So we're checking in now with that left upper trap, and we're going to feel a trigger point in there, right there. So this next part is just a static hold. The best way I could describe it is it feels like a frozen pea in there. And just sort of melting it with the warmth of your fingers, not from pressure. So you kind of, when you're working with a trigger point, you just kind of want to, there, good job, go right to the point of resistance and hold there. You don't need to push real hard. But if your instinct is to turn your head to the right, to get a little stretch under my thumbs, I think that's a really great idea. Megan, you want to do that? Yeah, stretch and come back. Yeah, and work through. So now in this way, the patient can control how much pressure there is because she turns her head to the right. It increases the stretch under my thumbs. And so she can exert control over the intensity of the sensation. Do you need me to stop?
No,
You good?
I'm going to turn my head anymore.
Go one more time. You can do it.
I'm doing it.
Just one more time. Good job. Good. Nice. And good. We're going to let that go. So I'm easing up my pressure now a little bit, but I'm not letting off entirely because I've got just the superficial fascia now between my thumb and forefinger. There's no muscle in there. And we don't forget that fascia can form trigger points as well. It's not just muscle. And we want to make sure that we address circulatory, microcirculatory issues and tissue restriction wherever it resides, not overly focus on muscle and joint, and also not overly focus on fascia because all those things are important. So coming now next to this proximal clavicle, and we want a little more movement here. So this is not a deep tissue. It's right there. I don't need to use a lot of pressure, just enough to kind of engage. So my right middle finger on the underside of the clavicle, my left middle finger on the manubrium of the sternum. And as she breathes, we're just kind of following, engaging that movement, and just seeing if we can induce like another millimeter. Just a tiny little bit at a time. And she's doing really well. It's good to be mindful when you're working in this area. Number one, the pectoral muscle. And don't forget the heart, the lungs. Her aorta is right here. And working with female patients, there's breast tissue in the area that you don't want to be pressing. So good. So what's happening now, right here, this is her clavicular part of her pec major muscle right here. And feeling some attachment trigger points where it inserts on the manubrium right around the level of rib 1 and 2. So taking a little time just to iron those out, just like that. Yep, good. Good. And now we have some movement there, and that's wonderful. So the next thing we're going to do is look at the rotator cuff, which means side lying. So please lay on your right side, face the door. So let's familiarize ourselves with what we see here in the side lying position. The latissimus dorsi, don't forget it starts way down here and comes up, forms most of the front of the armpit here, twists on itself and inserts on the proximal humerus. And it's really important relationship to the serratus anterior, which hugs the ribs from the front of the scapula. So hers, a big part of it is accessible right here, but it goes deep to the lat and hugs that rib cage and inserts on the front of the scapula, like all the way here. So there's some of it that is a lot harder to access, but really the important part for most shoulder issues is going to be this section here, this like 2.5, 3-inch section on Megan. It's right level with the inferior angle of her scapula right here and a little bit farther down, and where the lat crosses it, and really they tend to get stuck together right here. And I just almost always going to check in with that space because almost any shoulder problem is going to involve some restriction in there. And up here, the rhomboid, the mid trap, the low trap, the lower trap inserts as far down as T12, which is right here on Megan. And we can kind of see the border of it right there. And here, as it crosses over the lat, another space where there tends to be a lot of adhesion, and you can kind of see that chunk right there. Just make sure there's good mobility there. And coming up to the scapula, teres major, feels pretty good. Teres minor here, and infraspinatus. They're siblings. They both externally rotate the shoulder, and when there's a lot of tension in the pec that's tending to internally rotate, there's going to be overwork of the teres minor and infraspinatus because they're being stretched out. So in this case, it doesn't feel particularly restricted or adhesed, but we're going to give it a nice stretch anyway, just to make sure it gets some support. And coming up here, we have our supraspinatus, which is so often entrapped and impinged in an impingement syndrome. And on Megan's, it feels soft and pliable and really quite good. Also looking at the mobility of her scapula here. So I've got her elbow in mine, and boy, that's some really good movement of that scapula. Good. A little bit crunchy, but that's okay. Now let's look at abduction at the glenohumeral. So here she is at about 90, and we would really like to be able to get her humerus to 180 degrees, very much parallel with the side line of her body, and hers does. And for a lot of people, you're going to find a lot of restriction right here. As you get them to about 130 degrees, it just doesn't want to go. But Megan's is moving really nicely. And there's her triceps right there. A lot of times that's at the root of some abduction restriction, but feels pretty good on Megan today. So actually, finding there's not much to do there. And let's get you face down and feel that thoracic spine, okay? While we were transitioning to face down, Megan said she's really feeling it in here. Is that the right spot? Okay, so we're gonna double check and just see what we can find. This is a really nice position for working on the shoulder. Shoulders and abduction, it's pretty relaxed in this posture. So it's like a frozen pea, and we're just gonna engage it and give it some pressure, some compression, and not try to like snap it between our fingers, but more melt it. And you can see she's breathing nice and deep, really beautifully. And it's starting to move a little bit now, which is good. Good, good, yeah, good. It kind of just let go. Nice. So again, let's look at that superficial layer. So here's the muscle. I come off the muscle here, just on the fascia. Kind of feels like a pinch of the skin. But yep, right there in that fascia, there's that restriction, which is probably pretty irritated as well. Good. Did I get it? Good. And look how nice and jiggly that shoulder is now. Awesome. Good. Interesting. What I'm feeling now is we just did so much work on the left scapula that the right one is feeling kind of relatively stuck. So I think what we're going to do, Megan, is finish up working on your right side. Sound good? Okay. So again, seated, the inferior hand comes under and just kind of cups the head of the humerus. So my superior hand is free to mobilize the scapula, palpate the myofascia, get a sense of what's going on in the spine under there. And nice deep breath. And let this arm just be heavy. Good. On this side, we're feeling a little teres minor restriction here. You see that little chunk there. And let's lift your hip a little. Thanks. From here, I've got her whole arm, and let's do some traction. Nice deep fascial release, just with some gentle traction here. Pulling toward me gently but firmly, and what's the word I'm thinking of? Consistently, steadily. That's what it is. There's definitely a place for like rocking things and shaking, and those can be really effective, but for a nice deep fascial stretch, it's a steady hold and pull, kind of just at that moderate resistance. So if I let it go, I kind of would get a first resistance right here, and my second resistance would be right there, and that's kind of where I want to be in that second resistance. If we pull harder, there'll be another much firmer barrier. It's probably going to create some resistance in the patient. They're going to want to contract against it because it feels a little apprehensive, and we don't want to engage that. So a little bit of a handshake now, and I'm tractioning that deep fascia through the forearm. I've got her wrist extensor bellies right here in the palm of my hand. I've got my thumb and forefinger kind of making a little bit of a pinch just ventral to the radius and ulna. So she's getting a little stretch of her wrist flexors as well. And just a slow, deep, steady, moderate stretch. And I'm thinking when we're done with this arm, I'm going to do this to the left arm too. Megan says yes. Okay. Maybe we could do like a whole video one day just on all the joints in the wrist and hand and how to address those. That sounds like a good idea, actually. Just a little oil on my hands. I want to have a little bit of glide. I definitely don't want to feel like I'm stripping the skin ever. So inferior hand cups that glenoid and the superior hand on the distal humerus. So first resistance right there, second resistance right there. Good. It's good as a practitioner to watch your patient's breathing. If they start holding their breath, they are probably resisting the sensation. It might be a little too intense. So she's breathing really nice, deep and slow and regular, which is just what we want. Good. Now the forearm. So I can grab, and it depends a lot on the relative size of you and your patient or client, but in this situation, this works. So I've got her wrist flexors right here, and I've got her extensors right there, and I can kind of grab both and pull both at the same time. On her fingers and her palm, there's definitely some traction toward me, and it's just a slow, steady, deep stretch through the forearm. Feels so good. Yeah. I'm getting a massage later, and I'm going to make sure and ask Kate to do this to me. You can imagine I use my hands and forearms a lot. Thanks for being our volunteer today, Megan. I appreciate it. Okay. Thanks. Thank you.